Today is August 23rd, 2017. Kay Wagner Foundation Archivist is visiting with Dr. Bruce Erdmann, a retired Gunderson podiatrist. Dr. Erdmann began practice with Gunderson in 1973 and retired in 2011, totaling 38 years of practice.
Correct.
Is that all correct?
It is.
Well, welcome. We're pleased to have you here today.
Thank you.
Again, Pete Hawk from Medical Media is behind the camera. We'll start with where you grew up, Sparta, I believe.
Born in Sparta, and then at about age 2, we moved down to Chicago. My dad went to podiatry school in Illinois at the Chicago School of Podiatry, actually. So, and then moved back to, well, actually, Tacoma for a brief period of time, and then to La Crosse, where my father, joined an uncle, Hugo Protz, who was a podiatrist, kind of the first generation of podiatrists.
What was his last name?
Protz, P-R-O-T-Z.
Okay.
And I would say my father was kind of one of the first generation of the newer educated podiatry personnel. And so in 1950, at about age 5, we were back in La Crosse, and pretty much have stayed here, grown up, went away obviously for education, but then back. So most of my life as a native of La Crosse.
And did you have siblings?
I had one sister, Cheryl. She worked here at the clinic for a period of time in neurology, but just the two of us. Yeah.
Is she still?
She's still here. She is. Yep. She's not working at the clinic anymore, but she's in La Crosse, and so we get together and travel together. And her husband and I motorcycle together. He's my mentor, sort of say. Big enough to pick up the motorcycle if I drop him, and always kind of on the beam. So.
And how about your mom? Did she work when you grew up?
No. Basically, when we got back in La Crosse, she was a stay-at-home mom, and did a good job of that, but really never did nor needed to. I don't think that was a 50s thing. I think back in those days, for the most part, women stayed at home and took care of their family, sort of say, and that's what she did well. And
you attended Central?
I did, yep. I graduated in 1964. Somewhere between my junior and senior year in high school, I got talked into the Navy and went to boot camp between those 2 seasons. And so about 4 days after, I think it was more like 2 days after I got out of high school, I was in the Navy for a 2-year period, which was fortuitous, really, because it was during the Vietnam War, actually the startup of it, and I was able to go into the service as a Navy corpsman, so got my first taste of medicine really as a Navy corpsman.
Where did you serve?
I served aboard a U.S. Ship, USS Tidewater. It was out of Norfolk, Virginia, and spent a good deal of our time, however, in Naples, Italy, serving the 6th Fleet at the time.
Were you married at the time?
No. However, I met my wife, Mary Sue, I think when she was 14, and I was 15. She was a year behind me in high school, and had full intentions when I got out of the service of marrying her, which we did in 1966. Take that back, 1967. Because we just celebrated our 50th, so I think, yeah, that's how that equates.
When you were in high school, were you considering a career in medicine?
You know, I don't ever remember making that decision. I really don't. And however, it always interests me. And I hadn't made enough trips to the hospital as a youngster, as a patient. that it did always intrigue me. And when I had the opportunity to pick a primary direction, I guess, in the service, it was towards Navy corpsman. So, and it was it was a pretty exciting. It was 2 years of active duty aboard the ship. We treated things that I never thought I would treat, and it took a long time after I got into school to treat again. Injections and shots and x-rays and just a wide variety of operation on the sea at one time. So that really perked my interest. And my dad, being a podiatrist, was kind of a direction. But again, making that final decision, I really don't remember doing that, but that's where it ended up. So.
And you went to, it must have been called Wisconsin State University.
Yeah, I did 2 years night schools at Old Dominion in Norfolk, Virginia, and nailed away about 1.5 years of credits, actually. And then, UWL. And back when I was going through, it was a 3-year undergraduate protocol, intensified to get into podiatry school. And so I had a little over that, close to 4 years, but I hadn't graduated from here before I left to go to Illinois College.
And then how long was the education for podiatry?
That was a 4-year program in Chicago, and then did a residency in Mount Clemens, Michigan, for another 1.5 years, actually. And
then how did you decide to come to Gunderson?
My father was basically seeing most of the Gunderson, I'm going to say wives. Ruth and Dr. Sig's wife and Dr. Adolph's wife. And Avery was Dr. Sig's wife. Ruth was Dr. Thorow's wife. And so they kind of, I think, expressed an interest to having a podiatrist. And he was also taking care of Mrs. Train at the time, who basically wanted to consolidate care over here. So he got asked first if he had any interest at all in coming into the clinic, and I think he was pretty set in his ways at the time, really didn't, and that's when I was in my senior year, and he mentioned to Dr. Adolph that he had a son that would be graduating in the near future and ought to talk to him. And Dr. Adolph got a hold of me, and in between graduating and heading to my residency, I interviewed with him, basically. Well aware of Gunderson at the time, of course, and hung with the Gunderson boys, Dr. Thorow's kids, Finn and Rolf, and Lincoln for that matter, who's now here. And there was it was kind of a heritage here at the clinic, I guess. I was surprised in a way to get the opportunity, because basically my thought was I had already talked to St. Francis. I had things arranged for when I got out to be on staff there, and then go into practice basically with my father. But this definitely was the best route for a lot of reasons, really.
Were you the first podiatrist?
Actually, I interviewed first, formally. That preliminary one with Dr. Adolph, and then with the whole Dr. Rasmus and Dr. Overholt and Ed, Dr. Carlson. So yeah, I was the first to actually interview, but I had that residency to do. And in the interim period, a friend of mine, a high school classmate actually, who got sort of introduced to podiatry through my father again, had gone to school, and I kind of lost track of him. This was Mark Jolzerd, Dr. Mark Jolzerd, and he basically was in a position to join the clinic at the time. They were looking to add this discipline. And so I was the first, actually. I always draw that distinction, why not, to get the first letter, but Dr. Jolzerd was able to start first, and I'm really glad he was the one. He was take charge guy, and he didn't take no for an answer. We struggled with that our whole career together, but nevertheless, between the two of us, we could get things done. So I was really happy he started. He was a good man to have as a partner, and so no, I came a year later. He started in 1972, I think in July, and I came in July of '73.
There wasn't a department before, so talk about the demands, the challenges, and the memories of establishing that.
It was a journey, for sure. We started out in the surgery and neurosurgery clinic on the second floor, out of 2 rooms, and they hired a nurse for us, Rosemary Bennett, who I have the fondest memories. Rosemary's still alive. She's in her 80s and feisty as ever, and I'll visit her a couple of times a year when I'm back in Wisconsin. So it was Rosemary Bennett and another gentleman named Keith Thrun. Keith was, well, I guess he would be considered a physician assistant. I think he was at that point. He had gone to Iowa and took some training. He worked in ortho, and he was kind of cantankerous. So Dr. Hayden shipped him out to us, and thank God Keith really latched on, and he held our hand in the surgery, and knew his way around the operating room with the fine details, how to get along with nurses, bump-a-bump, and was a good man. He's quiet most of the time, but he never had to worry what was on his mind, because he would let you and everybody else know. It was always kind of damage control with Keith, but a valuable member to our group. So yeah, started out in the surgery clinic, and as a new discipline, I can't tell you it was easy. We were turf battling with orthopedics most of my 38 years. And I get it. I mean, I really honestly did get it. I mean, and back in those days, it was John Hayden and Doug Tompkins and Steve Haug. Those were the 3. And Dr. Tompkins and Dr. Hayden in particular had trained during the polio days, so they had a lot of footwork behind them. They were kind of willing to give it up, but they wanted the final say in just about any kind of procedure, new procedure that we would endeavor with. So it was always kind of a sparring match. It wasn't necessarily easy. Dr. Carlson was a really good mediator, and we were down in his office that first couple of years more damn times than you can shake a fist at, but he could always make sense of the situation. And same with Dr. Ottoff, really. I mean, I have to say he was, if anybody had, if I were to ask, you were to ask me about a mentor, it would be Dr. Ottoff. He basically had us doing procedures and things that I really didn't think we'd be doing, because he was in vascular, and amputations were part of that, and he told us to pull our pants up and get going. And parts of that I hadn't really been trained in, to be honest with you. Not that that's a big deal, but I just never did it. And so he would come up and sit in the OR and kind of observe and tell you you're doing a good job, and kind of pushed us, I think, to march on. That's the worst funeral I went to, as far as clinic docs go. Well, he and Dr. Carlson both were huge parts of our career to hear.
Did you have a number when you came?
Yeah, I was number 95. Dr. Jolsrud, who was a year before me, had number 10, so I had a feeling that he got somebody who was no longer with us for one reason or another. Number 10, I suspect, was probably a Gunderson, although we never knew that. So, yeah, number 95. I don't think there were many. I think I was the new number when I started. And kept that obviously all the way through. And I'm unsure as how many physicians are on staff nowadays, but I know it's hundreds. Yeah, yeah. It was an honor to be the first in this new discipline. But like I said, it wasn't necessarily an easy course. Gratifying, for sure, but not easy. From the second floor, we ended up down in the old dental clinic on the first floor. So I'm not even sure what that is right now, some sort of patient liaison, and stayed there a number of years with Gunnar Gunderson. He hung out down there. He had there were two of us, Podiatry and Dr. Gunderson, and CT scan and ultrasound, basically. And stayed there for a number of years, and then moved over to the old walk-in clinic over by medical education. And from there, when they built the new wing over our heads, basically, for orthopedics, podiatry got the bottom floor, and that, I have to say, was probably my proudest moment here. It was when we got our own department, that we had everything to say in its development and equipment, and it was our new home. I mean, not somebody else's prior to that time. It was really, really a nice thing.
Did you have students that came through?
We did. We took externs, and they would come and spend a month, follow us around, both in the clinic and in the OR. And we did that pretty much probably from I'm going to say 75. And actually still do. We still take students. As a matter of fact, I think it was in 1985, we established a residency. And that would be the other highlight of my career, is to be able to have been involved in the origins of that, because it was nice to have students for a month, but and then they'd go on their way and right back and say hi and keep in touch for the most part. But once the residency started, it went from a year to 2 years to now 3 years, and went from one a season to 2 in each of the 3-year programs now. And that's not an easy thing to do. The institution has to be behind it, and I'll never forget the day Dr. Overhaul called me over and asked me if we'd be interested. And our whole career, that was our interest. And we had talked to ortho about it, but they weren't big on training podiatry at that time. But he was, and so he got it done and started the program with our first resident, Richard Brunner, back in '85. And I think I should check my dates, but I think our first 3-year graduate was Dr. Dawson, who's now in our department, actually, and head of a medical education residency, actually.
What were the typical patients that you would see back in the early years? What were they coming in for?
They came in for a lot of structural deformity, the hammer toes, bunion type deformities, a large number of, and I think the reason we actually ended up at Gunderson, we being podiatry, were our diabetic population. That's, I think, why we started out in surgery, because, like I say, Dr. Ottoff was the vascular surgeon at the time. And basically, he was looking to do less amputating. And by that I mean legs, and trying to prevent things that started in the foot from blowing out of proportion and ending up needing major amputations. So a lot of diabetic patients. We saw a ton of them, and I think we got to be very good at salvaging those situations. And you know, I had that brought up at a meeting once in Overholt Auditorium with Dr. Reinertsen, who said, you know, he didn't see the number of amputations in this institution that he had previously had. He was an endocrinologist, treated the diabetic patient, and Dr. Ottoff got up and he said it's kind of a combination of all disciplines, but you know, podiatry being at kind of where this all starts as far as the major surgical procedures, complications thereof, I guess.
Is that still the case, or has medicine in your field and others, as you say, the cross discipline, improved over time?
It's improved a lot. You know, it really honestly has. But it still makes up a good percentage of our patients. That's kind of the silent disease. Patients, I think, are better are educated in their disease, the complications, what it takes to avoid them. But generally, because of circulatory and neurosensory loss in the foot, it still happens on a way too frequent basis. You know, it's sometimes the knowledge is there, but the wherewithal to follow instructions aren't, and even under the best of circumstances, and we get that as well. But that's another part of our job every day, is to educate, and it can start with as little as an ingrown toenail. You know, I mean, that's all it takes. And so early intervention, I think our department goes out and lectures fairly frequently nowadays into venues where, you know, those type of patients show up, and I think they've done an excellent job. One of them is now not full-time, but doggone close to full-time in a wound clinic with infectious disease and surgery, and although all of the members of that department see it, he's kind of the one that does, the major grafting and that type of thing, inpatient care of the diabetic. So now that made up a large part of it. The rheumatoid arthritic patient, we saw a ton of those in the early years. But you asked about education and medicine and treatment. That disease isn't, we don't see the complications we used to see when we first started. Major foot deformities, and it's just not that common anymore because patients are on top of it and arresting the process and avoiding some of these things that we used to see a lot of, actually.
Some of that, such as hammer toe, are genetic problem.
Yeah, it's generally an imbalance in the foot. You know, if it's a straight, you know, structural deformity with no underlying medical pathology, balance in the foot is a key thing, and that's an area that I really enjoyed dealing with. And through that, you know, proper foot gear, orthotic management, saved a lot of surgical procedures, yet when it was unavoidable, you know, we were a good place to go, and remained probably the premier area, place in the area, actually.
Did Mayo also have a department of podiatry?
Actually, one of our surgical OR nurses, Dr. Mike Quinn, was like I said, a surgical nurse here, and somehow ended up in our rooms, children and mine rooms, a good deal of the time as the RN. And I think through our process, he basically developed an interest and went back to undergrad for a period of time, and then off to Philadelphia for 4 years and did a residency, and now is at Mayo. The other one is Cindy Dooley, and she was a patient of mine during her younger years, and she is as well a member, so yes.
Does your field also utilize the physician's assistants, PAs?
You know, not to this day yet. Well, I shouldn't say that, because Keith Roon, our first surgical tech, was it was a PA. Mm-hmm. We don't utilize them as much now because of our residents. They're available, generally 2 on service at all times, and so we haven't had the need. Although recently talking to Dr. Jacobs, the successor to my department chairmanship, they've been talking about a PA or a nurse practitioner, mainly to meet the guidelines of Medicare, Medicaid nowadays. It's gotten to be such a quagmire. It's really one of the reasons, other than getting older, that my time came up and it was time to leave. Couldn't keep up with it all, and as much as our staff in this hospital and clinic did an excellent job of keeping us informed, they could barely keep up. So it was a huge factor for me in deciding to call it a career, along with Epic.
Mm-hmm.
Yeah.
Epic.
Yeah.
How did that change, enhance, or possibly decrease your interaction with patients?
It decreases my interaction with my current doctor that I see, and she's the first to apologize for it. It had a huge impact because there are steps to take before you can even start seeing the patient or listening to their complaint. Lots of little checklists that have to be gone through first. So there's definitely less time with a hands-on approach. Although our field is hands-on, it's diagnostic, but it's hands-on. We're a fixing department, I guess, in that it's not a lot of conversation. It's generally a lot of work, be it calluses or nail infections, or it's a procedural department. So it affects it a lot, and you cannot go on to the next patient until you check the boxes. You can't even access the medical chart until you finish. So it puts you on a schedule that I would say takes 25% of the time you spend with a patient.
But you have to do it on the spot.
You do, in the room. That's pretty much non-conversational because you'll get mixed up and check the wrong boxes, and then trying to dig your way out of that hole wasn't easy. And on the other hand, I think that it's going to be, it's not a problem so much for the newer people coming out. I think they get through that a lot faster. They really honestly don't know what it was like to spend that kind of time with the patient. And I think basically they'll deal with it better. I'm not sure that my age of patient's going to deal with it well, because we did know when the doc stopped in and had time to see you in the hospital, and that's just not the case anymore. It's production driven, and you know, I get that as well. It's just that's not the way. When I came into this clinic, Dr. Ed Carlson told me that if I came here to get rich, I was in the wrong place. If I came here to have people take care of everything else, billing, medical records, typing, forms, then I was in the right place. And he was right for most of my career, because I was left to do patient care. At the end, we had between 6 of us, a half-day secretary, who was there a half day. She was there in the mornings, not in the afternoons. Especially in the beginning of Epic, nobody to fill out disability forms. It was handwritten. It kind of reverted back to, well, I never experienced those days. This was a whole different thing for me. So that whole system, when it came in, was a real divergence over what I think most of us earlier practitioners had experienced, and didn't necessarily meet with broad approval. I learned Epic because I was determined not to have that be the deciding factor. Many of my friends, colleagues, internal medicine bailed, and that was the reason. It's not that they were unhappy with their practice or the patients they saw, workload, etc. It was mainly the red tape, I guess.
I wonder if the younger population of patients is more adaptable to the side of it with a physician who is managing this. In other words, the expectations are probably different than those of us that are older that are used to having a little bit more time to chat and more eye contact and that type of thing.
Right. I believe that's the case. I think it'll evolve. Let's see. The other part of that is billing's gotten more stringent. They're spending less time with a doctor, and so what I hear on the outside now is a lot of complaining about lack of doctor contact and high fees. So I'm not sure. I'm not sure how that'll work out. I suspect, yes, you're right, Kay. In time, it's going to be more acceptable. They won't know any different, and as soon as us old fogies go, keep reminding them of the good old days, as we like to call it on Thursdays. That probably will happen.
What have been some of the advances that in your field that have stood out over the past 20, 30 years?
Well, I think, it's basically been in the education process. When I came in, like I said initially, you could enter a podiatry college with 3 years of focused pre-podiatry. Nowadays, and I think there were, I think at the time, 4 schools of podiatry. And now you would have no chance of getting in, because I don't believe there's a program for a 3-year undergraduate degree anymore. It's 4 years, and a lot of our current applications have done more, master's degrees. We have one that we recently hired upstairs who was an attorney first and went back and got into the profession. So a really long educational process. We're glad to have him, because nowadays it's good to have an attorney around who's sympathetic to medicine. And I suspect as time goes on, he'll have more of a role here in Gunderson. So that 4 years is entirely more intensive. And when I was going to school, it was primarily school-based. And now it's really heavily school-based for a 2-year period, but then a lot of externship type involvement in communities around the area following established podiatrists with the didactic end of things. And when I graduated, there were a number of internships and residencies available, but a lot of states didn't require them. Nowadays, they all do, and so that's become the norm. And rather than going out and winging it, and kind of is what you do after 4 years, and so I think, and they've kind of matured from a 1 year to a 2 year to a 3 year now for full surgical privileges, and it's been a good thing. It's been a really good thing, and that's why I'm so pleased with Gunderson basically endorsing that movement and establishing a quality program. I like to say it's almost unlike any other, because our residents spend so much time in medicine and surgery and behavioral health, and I mean they get the total education here. And I've seen, our residents, because they were in mainstreaming with our medical residents, end up in cities where the medical residents go because they're used to having a podiatrist on board who's well versed in all phases of medicine. So I think the educational process is really the key.
Has that helped to create parity with the medical doctors as well?
Yeah, it has. It really honestly has. It's still, it's kind of like dental and oral surgery, for instance, and ENT. That was a long, ongoing process as well. But I think as those disciplines started training the oral surgeon and having a good deal of input into what they did, it was hard to deny them. And I think, yes, exactly. I think that's had a huge, like I say, huge impact on where our residents end up, especially out of this institution. As you have known quality and quantity in the people you treat. One of our podiatrists now, Dr. Jacobs, is on the board of the clinic, which I wasn't sure ever would happen. As a matter of fact, he's the medical vice president of the hospital. And if you would have told me back in '73 that was a remote possibility, because I'm not sure it was bylaw-wise back in those days. But, matter of fact, I don't think it was. But it goes to show you kind of where the maturation has evolved.
Same with chiropractors.
Yes. And you're going to have, I'm intimately acquainted with both here now. Well, the first two. And Gunderson did a good job of recruiting, number one, and getting representatives in that discipline as well who are going to represent their discipline well. So yeah, I think that's right. I think their educational process has improved, and there's still skeptics, but they are hugely busy in our clinic situation. Yeah.
Dr. Overholt had a lot of vision in terms of encouraging both podiatry and other fields of education and the residencies. Yes.
Yeah, he was, we've had good directors since. Dr. Ross, who was down in our area for a number of years, subsequently ended up at Rosalind Franklin as a dean, and that's where our podiatry school is now, Show College at Rosalind Franklin. And but Dr. Overholt, yeah, he not only good vision, but remarkable common sense when it came to the best care available. He was never opposed to advances in medicine or surgery. As a matter of fact, if you were on the wrong side of him, lacking advancement, you were in a war. I think of one dermatologist who ELO and he were at it constantly. And but on the other hand, yeah, he was the one really instrumental in establishing the podiatry residency. I don't think if it wouldn't have been for him, and Paul Halstead's father had a lot to do with it as well. And Paul Halstead was our second podiatric resident here, and his dad was a major supporter of the program, both financially and intellectually, I'm going to say. So, yeah, there was no sugarcoating it. He had expectations and a protocol that you were going to use if you were going to have a resident, and you weren't going to argue with him, and nor did I feel I was in a position ever to do that. A very intelligent man, taught good basic medicine, not over-ordering labs, not over-ordering tests. He was a diagnostician, and he tapped on your belly and listened to your lungs, and You don't get that on every visit anymore. You really don't. You get a lot of questions and a lot of computer, but and some, but not the way his residents were trained. And you know who he trained and who he oversaw, and that's who I ended up getting for my primary care, because I want that. I want the test I need, but I don't want tests I don't have to have. And that philosophy is still there because the people he trained are still here. But I can see that fading in the future too. I can see it. Medical, legally, there's a lot of reasons, but you know, with the CYB sort of mentality that we have nowadays, and rightfully so, I guess. So, but yeah, strong advocate of alternate fields and alternate thought processes to the care of patients. Yep.
You mentioned that you were chair of your department.
Mm-hmm.
Did you serve in other administrative roles, and how did that play a part in combination with your practice?
Really, my primary role here was department chairman, and that of podiatry, and that was, believe me, it was sort of a full-time job, because, as I alluded to earlier, it was a lot of there were a lot of, I'm trying to say this in a really nice way, conflicts of interest in the beginning, and it really never totally ever disappeared, and nor did I, because I was, and if I had to give my biggest accomplishment, is the fact that I didn't bolt because of those conflicts. We came close. Joseph and I both were ready to head out, and Dr. Ottoff again jumped in and got all parties together, and came to an equitable solution, and it kind of evolved as time went on. But that took a lot of my time. I did serve on the executive committee of the Wisconsin State Podiatry Society for a 6-year period. And like I say, it kind of was instrumental in establishing the residency and working on the training of it. But other than that, I was pretty well devoted to doing my job.
What type of conflicts?
Mainly turf battles. That's usually what it was. You know, it was, we're a new discipline, and to be honest, our forefathers in podiatry were undereducated. But so was medicine back in the 40s. You know, that just was the way it was. I mean, you know, and same with osteopathic medicine. We all evolved over time. And by the time I went through, the education was on par. I mean, we sat in the same classes as our medical counterparts. So, you know, it was educating those who were familiar really with the older generation, and that our main, I guess I'll say adversary, for lack of a better term, was the Department of Orthopedics. I mean, there was an understanding. I operated on several other wives. When it came to the foot, and yet when it came to new territory in those early years, moving on up, those were the battles. It took a lot of diplomacy, mainly because my partner at the time, Dr. Jolsrud, was, this is right, and this is the way it's going to be, and that wasn't the way it was going to be without some wiggling. And so it was kind of damage control all the time. It was challenging but interesting. And I felt at the time I was probably the best one to do it. So I developed some scar tissue because of it, but on the other hand, 38 years later, I got to retire from Gunderson. So I got to retire with a 6-man department, full residency, full surgical privileges. It was a good time to leave, actually.
What an accomplishment, though.
Yeah, I think that if somebody asked me what my biggest accomplishment, it was stay-to-itiveness, I guess, and persistence and diplomacy and respect to the people I was dealing with. Because like I said, Dr. Hayden and Dr. Tompkins were great surgeons. They honestly were. They were men of few words, generally, but great surgeons. Nobody could argue that, and didn't try. Just tried to get them to accept the fact that we're here, we're staying, and we're going to advance. Yeah.
Did your department also get involved in outreach efforts?
Absolutely, yeah. I was the first, actually, and ended up in Prairie du Chien for probably a 12-year period. Once every 2 weeks, I think it was. When we hired our fourth person, was Dr. Ringstrom, who just recently retired. He had ties. He came from St. Francis, actually, where we recruited him. And he was actually the first. It wasn't Quinn. It was Dr. Ringstrom. Practiced out of St. Francis for a period of time, quite a few years, actually. And he had rotated through podiatry and lacrosse as well, though, as an extern. So, as a matter of fact, I went out and got him to come to lacrosse to take that position because I figured it was good for our profession. But he ended up out in Viroqua and then Sparta, and now each of the members outreach. They're in Hillsboro, and I don't think we go to Prairie anymore because we've acquired a group down in Decorah that handles that. And but Toma, I don't even know her all anymore. Whitehall, I know for a fact, kind of all over. So yeah, very involved. It was a good thing for us to do because it increased our exposure in the region. Dr. Carlson really was the mastermind of outreach. I don't care what anybody else says. It was his baby, and I mean, he went out and got Farrell and Garrity and company to sign on, and which was a really good thing, and a really good thing nowadays, having that much outreach and that much influence in the tri-state area, really.
Did you serve on any administrative roles with Lutheran Hospital when it was its own entity, so to speak?
No, I never did. Had a lot to do with Dr. Schwem and Smith and company, but no, I never did. Again, we were new enough in there. I don't think they actually knew what to do with a podiatrist initially, so other than keep us busy, and which they did. It was a busy and is a busy department. So, and I really had very little interest in that. I was trying to keep my head on my shoulders, which for the most part, I guess I did. So, yeah.
What do you think your colleagues would say that you're known for?
What am I known for? I think it's as a negotiator. Because I did an awful lot of that's kind of why the department is where it is nowadays, which is back on the second floor where we started. Exactly in the same area. And yeah, I think it would be, yeah, as a negotiator. I would hope they'd say as a good surgeon. I know my patients liked me. So I always had reasonably high grades in that. So I think those are the major things.
Is there one or two patients that or experiences that stand out in your memory?
Yeah. There's Harold. who I took care of forever and a day, and Harriet, who was his wife. And Harold was constantly losing parts, digits and major parts of his foot, and he would always come in, and he had absolute faith in my ability when I wasn't always sure I was going to be able to get him through the next crisis. But he pushed me to, I think, 10 more wound lectures I had to with him, and courses to further my capabilities and ability, I guess. And so he was a major force for a lot of years in my practice, really.
Was it diabetes driven?
He actually had rheumatoid arthritis, but a lot of the complications that a diabetic also had with lack of circulation and a certain degree of neuropathy, and so the wounds were kind of similar, as was the treatment, really. Yeah. I had one other patient who had, most of my patients were pretty generally healthy. They weren't about to die. They basically were here to solve a problem, and most of the time we were able to help them. But I had one in particular that came in who was kind of a train wreck in general, and had to go to surgery, and he we got through it, but he had a lot of bleeding on the post-op basis, and actually succumbed to some of the complications of that. And it kept things in perspective for me that no matter what area of the body you're on, bad things happen sometimes. And I couldn't really take responsibility for it, but in a way I felt responsible. So I got a good dose of humility, and he was a major factor in how the rest of the 20 years went. So.
How so?
Paying more attention to the patient as a whole, and not just a slot on the OR schedule. We did a good job, I think, of assessing, but a lot of times the case was presented to us as, here it is, go do it, get it done. That was Dr. Otto's approach. And so that's how I learned. And he basically, that patient, made me critically aware of doing a little better job of background, I guess. Yeah. I was assured the outcome was written in sand, but on the other hand, it's a good dose of humility. So
he survived.
Actually, he didn't.
He didn't.
No, he didn't. It was a combination of other factors that got him, but part of it was blood loss. So it wasn't just me. It was one of the medical residents who changed dressings and then pay attention to the details, and just kind of a comedy of errors to let me know that even in a top-notch institution, mistakes can be generated.
Did he have a condition or something that created a bleeding problem?
Well, severe arterial sclerosis, rock hard arteries, and he couldn't stop bleeding, short of packing it off. It wasn't the standard, tie off a bleeder and be done. It was get the job done and pack it well, and we did that, but then it got unpacked a couple times and bled again, and so it was, and actually when he passed, I wasn't here. I was off, I think, taking surgical boards, and came back to find out that was the end result of all that, and it was difficult.
If you could change one thing in your years of practice here at Gunderson, what would that be?
Well, I guess another wise man at the clinic, Dr. Newcomer, during one of our battles, coined a phrase to me that I still use, and I use it with our residents over the years, and that's, to curb the impatience of youth. And I never liked that saying in the beginning because I wanted to get things done, but it's the truth, and as kind of proved by where podiatry is in this institution now. I think both Joseph and myself wanted it done yesterday, and changes, and it's kind of like the changes in medical records. Although that was a little more overnight, but it was a long time evolving, basically. And I think that's the key. That's the key for the young people coming in, is that if you don't have it right now, bide your time, because keep working at it, and you will get it if you deserve it. So,
Do you have any advice or words of wisdom to offer a young physician entering podiatry today?
I think if I had to, they're coming in extremely qualified right now, out of their formal training in school into a residency program. I don't have a lot to add with that, because I think basically the schools are doing a really good job of that nowadays. I think, and I can only speak for Gunderson, but we do an excellent job in training the young physician podiatrist. The part that they have trouble with sometimes is, and they come from all over the country, East Coast, West Coast, South, Canada, and Australia recently. And the thing that I spent a good deal of my time on was, yeah, you're smart, yeah, you know what you're doing, but you need to understand the culture of your patient population. And I spent a lot of time doing just that. In other words, this is the Midwest. This isn't New York City. Patients expect you to spend a little time. They want you to know their first name. If they took a trip, it's a good thing to document in the chart, and it's getting harder to do that nowadays because there's no checkoff box for that. But I think it's an important part of it to still be a human, and have some concerns and cares about them, not only as a patient but as a person. So I think that's my largest advice, really.
Are they willing to listen to that? Do they find that important? Understand the...
Yeah, I think most of them do. Does every one of them? No. I can think of a couple glaring examples, but nevertheless you try. I think that's a very important part of taking care of people. Is there's a personal side to it as well as a professional side, and that's what I grew up with. Probably you, and hopefully the ones coming up. But I think sometimes they get lost in the need to produce and move on and get to the next patient, and it's culture driven right now, and it's a part that Dr. Overholt would make dang on sure you knew about. I mean, that was his forte. He had a lot of them, but that was one of them. Is get to know your patients and get to know if you're practicing in the East Coast, it's going to be different. So learn it. Learn what patient's expectation is going to be in order to be successful. So.
Are the hours that are required as heavy as they were during the time that you practiced in in terms of on-call and weekends? Or does that maybe differ between
The saloons?
Yeah.
Well, it's gotten to be a lot more demanding. We being Jolsard and I, and probably Ringstrom, weren't involved in as much call. We took call, but it wasn't as much call as they do now. Now that they're trained in ankle fractures and that type of work, more trauma-related, they end up in the ER a whole lot more than we ever did, number one, and from the ER to the OR. So I think that's one thing I do hear is that the hours are, the way they have it set up right now, really demanding, and it sounds like it to me. So I think they're in the process of trying to work through that again, because you don't need tired residents. I'm not going to say tired. Tired's okay. Exhausted is another term, because we put the hours in. I mean, and I think our practitioners still do. Residents are protected now a little more than they used to be. Certain hours every week, and you can't exceed it, and they know it. So I don't think that, as a rule, they have rights that they never had before, and I think it's a good thing. I don't think it's bad. I think a tired resident is not necessarily a high functioning, and so I think are exhausted. I'm going to use that term again. So it's not all bad, but I think there have to be limitations as well. So
were some of those driven by the ACGME?
Yeah, absolutely. Totally, I think, driven by it. I don't see that happening here or anywhere where there's a program if it wasn't. Mm-hmm. And I know, for instance, general surgical residents probably don't pay attention to it because it seems to me they're up there all the time, still. But don't complain, so, that's good. That's part of their culture, I guess. So, otherwise, I think it's pretty well followed in the institution,
Are podiatrists hard to recruit, or is there a shortage?
I think that they're anticipating a shortage in the next few years. But like I said, I think there are 7 schools right now, which is a quantum leap from when I was there. So they are graduating more. The demand's up, and so no, I wouldn't say there's a shortage at the present time. Well-trained young men and women. There's when I was in school, there was 1 woman in the 4-year program. I'd say 50 to 60% now are females who are, and for the woman, it's kind of it is a good profession for them. I think the hours are good if they go into private practice, and that's becoming a vanishing beast as well, but set their own hours and can be there and still be productive and fulfill the expectations of their education, I think. So it's changed.
You've donated to the foundation over your career. What motivates your contributions?
Gratitude. Gratitude for the things we've talked about, accepting us in the first place, allowing the department to expand, embracing a residency. I think the training part of this is a key part of Gunderson's success, and it just is. And I find that it stimulates, the staff to stay on the beam, and you got to be able to compete with your residents. So I think that's a huge part of it for me. I'm a firm supporter of it. I think it's one of the greatest clinics in the country, and I don't think people in the area sometimes understand just how great the level of care in this community is, not only here, but saying elsewhere. I mean, it's basically, it's hard to beat. I'm currently retired, obviously, in Florida for half a year. However, when the day comes where either my wife or I demand more care, I can guarantee it's not going to be in Florida. It'll be in La Crosse, Wisconsin, where doctors talk to one another and consults can be made, and bright young people continue to be educated.
Sounds like you have a busy retirement.
Yes, I do. It's I made the statement when I walked in off record that work was overrated. I'm not sure that's really true. That's my joke. But retirement is awfully sweet, and I have discussions with some of the ones that can retire here and are hanging on, mainly because I think they don't have much of a off-hour life. And I made sure that I did take time for family. I loved a motorcycle. I did that all the way through my career here against Dr. Overhalt's protests. And continue to do it. It's kind of my release. It always was when I was working. I didn't have to talk to anybody. Talk to myself and get all the right answers. And I try to stay physically active. My wife and I both swim pretty much 6 to 7 days a week, and swim distances. And down south in Florida, when we're there, there's trap shooting and boating and vacations away from Florida even. So yeah, we stay really busy. We have 4 children, 8 grandchildren. We're enjoying them. I try to step in and help where we can.
Are they close by? I know one is.
One is here. My son Brian is administrative. And my daughter was a nurse here for a period of time. She is in Minnesota, just outside the cities. And her husband's a PA who also was worked in cardiology for a period of time here. My son is middle son is a teacher in Oshkosh. And my oldest son, who's adopted, is in Green Bay. So yeah, the family is pretty close. I mean, reachable. And we make darn sure that if they choose, they can come down south during that 6-month period, or my wife would have never moved in the first place. And she's free to travel back and forth when the need arises, as we both are. So stay busy.
Anything else that you'd like to include that I haven't asked?
No, I think this is a good project, though. I think, we talked about some of the difficulties initially with accepting a podiatry in this institution, and I don't dwell on that. I honestly don't. When I get together with the new staff or the new residents, it's not, you should have been here when. I don't do that. But nevertheless, I think it's good to remember the past to a degree. Not to dwell on it, but to acknowledge it. And so I think what you're doing is really a good thing. I think, from the Maharises and the Jeromes and the Erdmanns for that matter, you give a good idea of some of the maturation that's gone on here. So, yeah. I think that'd be it.
Well, thank you so much for coming in.
My pleasure.